You may also start with the goal of merely wanting to provide comfort or palliation to the patient, and the patient does extremely well. There's no reason why you can't shift to a higher goal, which is to prolong life. These goals are interrelated, and it's the medical care team that helps to decide which is the appropriate goal for this patient at this point in time.
Thank you very much, Professor. And of course, the need for cancer and palliative care services in the country continues to grow. And of course, that places a huge burden on the healthcare workers. What, in your view, Professor, do you see as the main challenges for our healthcare workers in the field of cancer and palliative care? And how can we address these challenges?
The first challenge that came through my mind was the fact that a number of healthcare workers have contracted COVID-19. They've been infected, leading to long periods of isolation and absence from work. Secondly, a number of healthcare workers have lost their jobs as projects that were closed because of reallocation of resources to COVID-19. Some oncology clinics were reassigned to COVID-19 screening rooms. Plans to open or to establish oncology clinics in some countries had to be shifted as responding to the COVID-19 pandemic was prioritized over everything else. Then the high risk of patients in need of palliative care because of compromised body immunity. So the patients as well as the physicians, because of compromised body immunity, have become victims of COVID-19. In Uganda, the use of borders to deliver painkillers with the training or a tracing system to ensure that the medications are delivered to the right person and in good time needs to be considered. I believe these borders can help us deliver, especially people who cannot come to hospital. Then the care for patients in need of palliative care is more than a job to the poor doctors and nurses. It is a deep calling. The doctors, the medical team, is a deep calling. Relatives may not be able to visit the terminally ill patients at their home, and all the drugs available at lower level are, we should ask ourselves, do we have available drugs at lower level palliative care and cancer care units other than at Mulago Hospital?
So, Professor, I want to pause at that and then move on to Dr. Dung, and I'll come back to you later. Dr. Dung, you have really worked in these fields, in cancer care, in palliative care for many years. And in 2014, the World Health Assembly passed a resolution that acknowledged palliative care as an ethical obligation for governments. But for governments and for development partners and all stakeholders to be able to really focus on ensuring access to palliative care, it is important that they understand what is meant by palliative care. Dr. Dung, can you help us elaborate to the delegates and the viewers, really in simple terms, what does palliative care encompass? And what are those key things we need to do to ensure that the decision makers, policy makers, and all stakeholders understand it for us to work together to realize access.
Thank you very much, Madam Chair. It's very nice to get a question like this because it gives me an opportunity to help clarify on this issue that has been evolving. Initially, we had a confusion between hospice and palliative care. And hospice was, as to many knew, the kind of care you give to a pilgrim that is so sick and they need somewhere to rest. Then it became a philosophy of care. And in 1990, the World Health Organization defined palliative care for the first time as the kind of care you give to a patient, and here they're looking at cancer mostly, to a patient with cancer where everything has failed, and now you resort to that kind of care. With the advent of a number of illnesses, including HIV, including discovery of protease inhibitors and other antiretroviral medicines, and during that time when the HIV epidemic went up, we're all practicing palliative care, not only for cancer patients, but for even people with HIV, AIDS, and others. So in 2000, the definition was revised to look at it as an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. Remember, here we have moved from life-limiting to life-threatening, and focusing on the fact that palliative care should help prevent and relieve suffering, through early identification of challenges, and then we address them. If you address suffering in a patient with cancer, they can actually live a better quality life. When you address the pain that they have, people can live quality life, both adults and children. So, as the moderator has said, palliative care is explicitly recognized under the human rights to health. It should be provided through person-centered and integrated health services that pay special attention to the specific needs and preferences of individuals. And now we know for sure that it's not only for cancer, although right now we are focusing on cancer, but palliative care can be provided to other illnesses. We need to emphasize the fact that pain control, both physical and non-physical, are extremely important in palliative care. Control of other issues is extremely important, and we don't provide palliative care without other aspects. That's why we use it as an approach. If a patient is diagnosed, say, with breast cancer, the way you are going to break the news to them that you have cancer of the breast, and you may need to undergo surgery, and you may need to go through this and that, it helps them to understand the process better. And if you promise and implement what you're talking about, that when you have pain, you'll be able to control this, then they're going to understand and say, oh, so what I was thinking about may not be what it is. And then they can leave. We have to remember that opioids are extremely important when you're talking about pain control in cancer and palliative care. And access to opioids, especially oral morphine, is extremely important if we are to implement palliative care. But the challenge is that up to now, there is insufficient access to palliative care. There are so many people who cannot access palliative care, and there are quite a number of reasons, Madam Chair, if I'm to continue. For instance, national health policies and health systems that do not include palliative care. We are glad ours does, but others don't. Then training on palliative care for health professionals is often limited, okay? And access to opioids for pain relief has been really, really limited and making it hard for people to access palliative care. But also lack of awareness, and I'll end with this one, lack of awareness, especially among health workers, especially among policymakers and the general public, who look at palliative care as, by the way, and some people can tell you, no, our patient is not yet ready for palliative care. It has been a barrier to effective implementation, Madam Chair.
Thank you very much, Dr. I want to ask you one difficult question, but I'm sure you will answer it. We witnessed a lot of suffering since the emergence of COVID-19. Did you see a place for the palliative care approach, and do you really feel that approach was used appropriately to support the suffering that has come with COVID-19?
COVID-19 has been a real challenge. You know, when I was talking about the definition, I talked about patient choices and preferences. And there's evidence to show that many people with life-threatening illnesses maybe prefer to be with their families. Here comes a situation where we have a person facing death with COVID. They're locked in a room all by themselves. They don't have anyone to take care of them. They don't have anyone to talk to, much as they have masks on them. So it became really a challenge to implement this aspect of care, because you want to protect the person who is taking care of the person with COVID, but you also want to help the person who is suffering with COVID. What some institutions did was to introduce private rooms for patients, where if you're the care provider, you remain in there and stay taking care of this person. But it's been a big, big challenge, because we could not deliver the best aspect of care for people who had COVID-19.
I think I want you to build on that, being one who coordinates palliative care throughout the country. What kind of strategies have we adapted for providing palliative care to address the suffering that has come with COVID-19?
Thank you so much, Atia, moderator, for this last session of the third Uganda Conference on Cancer and Palliative Care. And I thank the leaders who are here for the good effort and for the answers they have given. And of course, for the people who have been watching us since we started up to now. And thank you for the question. Indeed, COVID-19, as we mentioned yesterday when we started the conference, has had an impact on the services that we offer. And if I speak on behalf of the Palliative Care Association of Uganda, but also on behalf of the hospices and palliative care organizations in the country, most of them have had to reduce or scale down on their operations to fit within the standard operating procedures. And that has impacted on how many people can access the services. Last year in April, when we did a survey, when the lockdown had just started, we found out that actually hospices had reduced the number of patients they see by half, because they are not seeing any more patients at the outpatient department, and they were continuously being innovative to see that they reach patients with few outreaches and home visits, and also using mobile phones. And I'm glad Professor Rain spoke about the need for us to streamline and utilize the available means such as border to improve the care. And some hospices had done that, but to a smaller extent. And just like Dr. Dung has said, we found the approach of treatment COVID-19 rather tough for the wishes of patients. And we know that palliative care providers, for example, at Mulago, did a great job. They were in there to provide care
to participate within the teams that saw patients at that time. But we are glad that eventually, because as the association we are part of the committees that discuss this, we are part of the case management pillar and then the psychosocial support pillar. And through the discussions on the mental health and psychosocial support pillar, we are able to inform. And later on, the approach when it came to patients going back home, the palliative care providers really played a great role in trying to make sure that they address the fears among the family members. And they continue to play a great role even now on vaccination to appeal to the people. And it's a voice that we can amplify at this meeting, that please get vaccination, get the vaccination when it is available, because, and there is an important scenario that always plays on WhatsApp, that all of us survived the 6 killer diseases, as we know, because we are vaccinated to some extent. And so let's not be negative about the vaccine. Let's follow the Ministry of Health guidelines. Let's follow the scientific advice. Let's be vaccinated when an opportunity has presented itself.
Thank you so much, Mark. Moving on to Dr. Rem. Dr. Rem, I would like you to make a brief comment on what has been the impact of COVID-19 on both adults and children with cancer at the Uganda Cancer Institute. But after that comment, again, we'll move on to, we know that from the National Development Plan 3 of the government of Uganda, access to cancer care has been prioritized. And some of the strategies being used to realize that goal is ensuring operational regional cancer centers in Arua, Mbarara, Mbale, and Gulu. We also know that government wants to see the Uganda Cancer Institute become an oncology tourism center for Eastern Africa, but also for the African region. Dr. Rem, could you maybe share with us what progress we are making towards realizing those milestones, and what we need in terms of resources to actually fully realize that dream?
Thank you very much, Chair, for those wonderful questions. I'll start with the first one about the impact of COVID-19 on cancer patients or cancer care in general, both in children and adults. As you know, cancer is one of those diseases that from the word go, when COVID came onto the scene, was actually marked. The cancer patients are the high-risk group. And as a result of many things, first of all, the disease itself is heavily mediated through the immune system. So that means that cancer patients actually have reduced immunity. And that reduced immunity is further affected by the treatment that they get. So if you may say, I think cancer patients, from the word go, they were already heavily disadvantaged. So that's the first point. Then, of course, coming to the workers themselves, during the COVID situation, many things happened, not only here in Uganda, but the world over, where prioritization happened, and cancer in most places actually took a backseat because all the focus was on the disease or COVID. Now, if you combine these two together, you'll find that actually the people who are supposed to benefit and protected from the COVID situation, who are the patients, first of all, they were lacking in emphasis in as far as care is concerned. And then secondly, even the health workers who are supposed to look after them, they were kind of left now to kind of go into other services. That is in many other countries. The good news that I want to say is that in Uganda here, because of our right policy, the Uganda Cancer Institute remained open and to provide the services for the patients. Of course, again, access was affected because of the measures that were aimed at curbing COVID. for instance, the lockdown and then the curfews. That meant that actually cancer patients, even though the services are there, they cannot access the services because of the measures that is meant towards COVID. But in addition to that, in as far as the health workers are concerned, they also became a victim of the situation, just like any other persons, because some of them also got infected with COVID, and that reduced further on the workforce that we have. So you can see that, there are multiple ways by which COVID affected our cancer patients. To make matters worse, they were nowhere actually among the priority areas in as far as the response is concerned. But one good thing is that we have always been dialoguing and bringing up these issues to the extent that now we can say cancer patients, as well as also patients with other non-communicable diseases, are getting also the attention that they deserve, albeit a little late. So that's what I can say about the first question.
Thank you so much. And I really hope we can take lessons, because COVID is still with us, and hopefully the lessons should inform how we can revise the national response to ensure that other people with other disease conditions are not neglected. Dr. Ram, do you want to go to the next area?
Yes. The next question actually is a very good one that you have posed. And you are really asking what has been our government commitment in as far as the fight, if I may use that terminology, against cancer is concerned. I want to say I think our government has been very supportive in this area, and that is largely because of the background that Professor Olwenya has very eloquently given out. The Uganda Cancer Institute has been in existence for over 50 years, and it has actually taught many people about how to fight cancer, and it has been a great research center for many, many years. But the fact that we have had a lot of political issues in this country, that meant Uganda Cancer Institute was not spared, and that could be explained the reason why, in the first place, people are ignorant about cancer in this country. Secondly, some of them also do not know that there is a big asset that they have in the Uganda Cancer Institute that is known the world over, except by people here in Uganda. But that is also fast changing. I must say that our government has put commitment into cancer care. The first indicator in as far as policy commitment is concerned is that the Uganda Cancer Institute is established by an act of parliament. And that act of parliament stipulates that the Uganda Cancer Institute should concentrate on nothing but cancer by coordinating all the responses of the government of Uganda in as far as cancer is concerned. And this includes actually some aspect of palliative care. As my colleagues have just said, palliative care in as far as our cancer response is concerned is part and parcel of that response. Of course, we need also to expand that to other conditions. Number two is that the subsequent two national development plans, that is Development Plan 2 and Development Plan 3, have included aspects of the importance of fighting cancer, and the Uganda Cancer Institute is the institution that is supposed to make sure that these aspects are actually in the National Development Plan 3 that we are now operationalizing is achieved. And this is aligned with our own Uganda Cancer Institute strategic plan. So in that aspect, of course, that means resources are being appropriated towards our response to cancer. The question is the resources appropriate in terms of, is it enough for us to handle the challenge of cancer? The answer is no. And the other question you are asking, are these resources that are being appropriated actually enough to make sure that the Uganda Cancer Institute lives to the build expectation that is expected of it? For instance, decentralization of services, making sure that we have all the services at the lower level. And then number two is working as a regional hub, as the East Africa Center of Excellence. And then number three, does it have the resources that is needed to make it actually the center for innovation and research that is expected of it? That answer is no, because this requires a lot more resources than that. But that said, of course, we have the prioritization of those services that we are doing. Number one, with the little resources that we have already established basic services. And these basic services are actually now functional. And the next thing for those basic services is for them to actually be extended to the lower level. At the lower level, the midpoint is going to be our regional cancer centers. And I'm happy to inform you that that is already in process. And then the next level is to go to the community. That means going to the health center 3s. And now I'm hearing about the Paris model. We must be there. Cancer services must actually be part and parcel of that model. And then, of course, the other aspect that maybe I should bring up now here is the next level that we need to move. That means we should actually move into the business aspect, which is also captured in the National Development Plan 3. That is making the Uganda Cancer Institute, or Uganda as a country, a tourist destination in as far as cancer treatment is concerned. But that requires a lot more investment than what we have. And then, of course, the next level is making the Uganda Cancer Institute the research hub, because we have a lot that we can actually bring out in terms of research, and this can also actually be plowed through innovation into making Uganda actually the maker of researchers in as far as cancer is concerned. The reason is simple. We have certain cancers that are only seen here in Uganda. We call them endemic malignancies.
Thank you very much, Dr. Ray. Maybe you can also say to the delegates which of the regional cancer centers are currently operational.
So that's a good question, because it is good to clarify this. When we say in blanket terms that we are operationalizing regional cancer centers, and we mention Mbale, Mbarara, Arua, and Gulu, most people already want to see physical infrastructure. But our approach has been two-pronged. One is functionality, and then two, the physical infrastructure. In as far as functionality is concerned, our centers in in Mbarara and Arua have some degrees of functionality. The functionality in Mbarara is a bit higher than the functionality in Arua. In terms of the physical infrastructure approach, that has actually been hampered by lack of resources. As I speak now, we have done the feasibility studies for this infrastructure in all the 4 regional cancer centers. But we have only got resources to operationalize one. That is the one in Gulu that we broke ground for in August on the 13th of this year. And the construction work is going on. And my appeal to our government, my appeal to our policymakers is that this is enshrined within the National Development Plan 3 that is going to expire in 2026. By 2026, the public, the people of Uganda would want to see 4 regional cancer centers. One in Mbale, Mbarara, Gulu, and Arua.
Thank you, Dr. Rem. Well, with COVID-19 and the restrictions that come with the travel, we probably, as Ugandans, want to see the regional cancer centers much earlier than 2026. So I hope we can all engage government so that these centers become operational earlier than 2026. Moving on to Mark. Mark, I know the Palliative Care Association of Uganda is doing a lot of advocacy and a lot of great work to ensure that there are policy frameworks for palliative care, national strategies, the political will. And indeed, we have all the political will for palliative care in this country. Palliative care is part of the minimum health care package of this country. And we have it in the health sector strategic plan and many other frameworks in the country. However, this is not matched with the level of access to services. I think currently we are just over 10%. I'm not sure that has changed significantly. Why is it that we have the political will, we have the policy frameworks that is not matching with services, and what needs to be done to ensure that that is matching with the policy framework? Because Ugandans are looking for hospice and palliative care services, they can't access them.
Thank you so much, Chair, and for a very good question, which requires a whole hour to answer, but which I must answer, I think, in 2 minutes, so that we close. But the good thing is that the Palliative Care Association of Uganda and with partners with the African Palliative Care Association, we have developed what we call the Essential Palliative Care Package for universal health coverage in Uganda. And this Essential Palliative Care Package is available for people. For those watching, we can share that online. And for policymakers like government, we have handed this over and advocated about it. And so that will address this question, that this information is available. But let me mention things that are in this package very quickly. Palliative care is essential to the right to health, and is actually part of the definition of what universal health coverage means. That all of us should access health without being constrained by our financial ability, and that this should not impact on us to take us back to poverty if we have been from there. These are the 4 things we put in the Essential Palliative Care Package. Number 1 on top, we talked about policy, and we combined it with investment in this service. We do not have a national palliative care policy. We have been appealing, we have been supporting the ministry, and we still add a voice that we need that. But these ones are what practically we want to see, and I'll go through them very, very briefly. This country is blessed because we already have the oral liquid morphine, which is an essential medicine in the management of pain, as Dr. Dung has explained. But there are other medicines that need to be included in the essential medicines and medical supplies list. They are listed in the package. The second one is on human resources and the coordination of the service. The ministry has created a division of palliative care. We need to see that division with enough human resource. We need to see the coordination from the national to the regional to the district and to the palliative care teams within hospitals. The Director General of Health Services issued a directive in March this year that all hospitals must have palliative care teams. We need to see that directive practically being implemented. But it can't be implemented quickly because of a number of issues that the Ministry of Health and all of us have to work on. We need more people trained. We need more resources available for hospitals to do that. We need more conscientization and sensitization, like the definition has been said here. The third thing are essential supplies recommended for use at home and in hospitals. And maybe this is where I can maybe use 30 seconds, 1 minute, and even if I stop there. When patients go to the Uganda Cancer Institute, they receive very good care from the doctors that are there. And right now, as the association, we receive credible and important information from people who come to the Cancer Institute. Everybody is praising. I was making people laugh at lunch that actually people say, surprisingly, I was handled very well, I have my prescription very well, but there are essential commodities. For example, we talk about colostomy bags that people don't access quickly. We talk about gauze. Sometimes it looks like so simple, but some people, when they go home, they can't access that. And we are saying that let these be provided. Let these essential commodities, essential usable things that the patients need to use, be available, the bandage, the gloves to use at home. Lastly, we are talking about psychosocial support for persons who need palliative care and are in homes. Now, palliative care improves the quality of life not only for the patient who is sick, but also for the immediate caregiver and also for the family. This care for the family cannot be done at a health facility. It must be done at home. We are saying to the government in the essential package for palliative care, if we are to achieve universal health coverage as it is and what the government is committed to, and the Office of the Prime Minister has come up with a framework of how to implement the SDGs and to achieve them, we need to see the healthcare system go at home to find a patient who has been discharged, and this can be done very well in collaboration with hospices, with the civil society. And this has been demonstrated very well, even by this conference, that it is possible for government agencies to work with civil society and bring out complementary efforts to address a service. Thank you, and essential palliative care package is available for people to look at. Thank you so much.
Okay, so we do have Professor Julia online, who is going to perform the final small but very important event of this conference. And I wonder whether UBC team, we can have just parting shots from the panelists in terms of time. Okay, so I'll ask Mark first to give us your parting shots. Focus on your perception on is palliative care an issue of just civil society, or is it a business for everyone, in just 5 seconds.
Thank you so much, and thank you so much everybody who's been online and on this conference. Palliative care is an approach, as has been described today and yesterday. This is an approach that must be utilized in the care or for people or individuals, both adults and children, who are diagnosed with life-threatening illnesses. This is an approach that we appeal to be integrated into the care. This conference has shown that actually this is not an issue of civil society, as has been spoken about in the country. Dr. Rem, who heads the Cancer Institute, has affirmed to all of you that the Uganda Cancer Institute utilizes palliative care as an approach into the services they offer. This approach is for all of us. We appeal to the government to make sure that all hospitals, that the entire healthcare system integrates palliative care. And I thank you, and I thank the panelists, and I thank everyone for the great conference we've had. Thank you so much.
Thank you so much, Mark. Dr. Dungu, in 2 seconds, your parting shot.
Thank you very much. Indeed, palliative care, ladies and gentlemen, is most effective when considered early in the course of illness. Early palliative care not only improves quality of life of patients, but also reduces unnecessary hospitalizations and use of the healthcare services. So we need to embrace palliative care as early as possible.
Thank you so much. Dr. Rem, any parting shots?
What I can say is that cancer care is a multidisciplinary care, is a multidisciplinary approach, and palliative care is part and parcel of that, and we call all that comprehensive cancer service.
And finally, Professor Lane, do you want to comment on quality of life that has come up, and final on vaccination?
Thank you, Madam Chair. Quality of life was mentioned several times during this discussion, and I guess during the entire conference. Now, I happen to have been a director of Quality of Life Center in Cancer Care in Manitoba, Canada. And we came up with a definition that is currently accepted for quality of life. And one of the definitions says it's the gap between the expected and the reality in life. If the gap is narrow, then you have a good quality of life. If the gap is widened, then you have a terrible quality of life. And we have instruments which have been translated in Luganda and Swahili to assess quality of life. The second point I would like to talk about is the vaccination, efficacy of vaccination.
Professor, in 1 second, I see the team, the UBC team.
Okay. I don't quite know. We don't know the efficacy of COVID-19 vaccination. We don't. But we can borrow a leaf from vaccination of hepatitis B. And the study was done in Gambia, in West Africa, And it showed that by vaccinating children with hepatitis B vaccine, about 90% of them benefit from the vaccine, as opposed to those who didn't get the disease, who were in the control group. And the numbers there is about 30% who did not suffer.
Yes. So are you calling upon the delegates and the general public to respond to COVID-19 vaccination then?
Yes, I think the one vaccination against hepatitis B, which was done in Africa, that showed us that the COVID-19, that hepatitis B vaccination was very helpful in preventing new diseases coming in and in preventing chronic carriers developing it or becoming chronic carriers. Now, that's a leaf we can borrow from hepatitis B. And since the vaccination has only just begun for COVID, I think we can borrow a leaf from hepatitis B.
Thank you so much, Professor, and thank you so much to our panelists this evening. Thank you to our delegates, both physically here and online. And we really hope that the lessons from this conference are going to enable us improve cancer and palliative care services. I want now to turn on to a different final element of the conference by welcoming Professor Julia Downing, who is online. Professor Julia, you're very welcome. And Professor Julia Downing has practiced palliative care in Uganda for a very long time. She has also worked with the Palliative Care Education and Research Consortium, which is based here in Uganda. And also she's the CEO for the International Children's Palliative Care Network. Welcome, Professor Julia, and she's going to take us through the awarding ceremony for the best oral presenters, and also will share brief highlights of the 3rd Uganda Conference on Cancer and Palliative Care, and that will close the conference. Professor Julia, over to you.
Thank you very much, Fatia, and it's good to be able to join all of you at this conference. It's been an exciting conference. I don't know about you, but I wasn't quite sure how it was all going to work. But it has been a conference with a difference. We haven't seen scenes like this at our PICAO UCI conference before, and it's been so great to have the conference televised, to be able to reach so many people. So we've had some people in the room, in the TV studios. We've had some people watching via Zoom, and we've had some people watching via the television. We've had a large number of participants. We know we've had over 350 online. We've had those in person, and we have no idea how many we have reached through the TV. Hopefully many, many, many more. So it's been great opportunity to extend information about cancer and palliative care. And of course, we've had satellite facilities around the country. It's been a broad scientific program with lots of abstracts, lots of plenary presentations and poster presentations. We had, of course, our opening plenary session, and we were delighted to have such eminent people with us to open our conference. We had the awards from the UCI and from PICAO, and it was great to be able to acknowledge the work done by these awardees. We've then had some breakaway sessions yesterday looking at innovation and creativity and how we care for the vulnerable populations. And then, of course, we had a panel discussion in the evening, again, getting to grips with some of the important issues around the experience of healthcare providers during COVID-19. Then this morning, we had another great plenary session. It was a full and varied program. We covered many different issues, and it was so important in setting the scene for us as we think ahead in terms of how do we live with COVID. Many of the presenters reminded us that COVID isn't going to go away. it is going to here to stay, and how do we work around it to provide good cancer and palliative care in Uganda. Then we had more breakout sessions looking at sustainability and, importantly, looking at resilience and how we as healthcare professionals care for ourselves. We also had 2 workshops looking at integrating pain management and improving data, national data on palliative care services in Uganda. 2 key issues, and I know that there's ongoing work from the World Health Organization in both of these areas. Some of you will have seen the posters, and I believe they're going to be up on the website alongside all of the presentations and the pre-recordings, and some of them are available, the recordings, on YouTube. Do please look at the posters. There were over 20 posters looking at different aspects of cancer and palliative care. So, the Oral Presentation Award, well, we're delighted that the Best Oral Presentation Award has gone to Dr. Barnabas Atwine from Mbarara University of Science and Technology. And he spoke about money was the problem. Caregivers' self-reported reasons for abandoning their children's cancer treatment in southwest Uganda. Such an important issue. And I know that Dr. Barnabas will be getting his certificate and being presented with his certificate from the PICAO team. Another congratulations go to everyone involved in palliative care. I think we were reminded that it is 28 years old in Uganda, and it's been a privilege to work with colleagues in cancer and palliative care over those years. So many thanks go to the organising committee, the scientific committee, the ICT committee, finance committee and publicity committee. For the UCI team and for the PICAO team, normally we would have a photo of everyone together. Also, a massive big thank you to UBC. I mean, it's been so exciting, the way that you've worked with us on this and that you've worked with us to get information about cancer and palliative care out to the community across Uganda. So thank you to everyone who's been involved in making this conference possible. This conference that has been so different, but so exciting as well. And a big thank you to our supporters, our sponsors and the Ministry of Health. As we leave, just a quick reminder that next month we have both on the Hats On for Children's Palliative Care Day and World Hospice and Palliative Care Day, which will continue this theme around leaving no one behind, ensuring equity in access, which has come up both for cancer and palliative care throughout this conference. So just a few pictures of people from the regional hubs, from within the centre, from those of us on Zoom, as we have shared together over these last 2 days. We would like to thank everyone who's made it possible. And it has been a privilege to be a part of this conference. We will be writing up a conference report that will go up online and we will share it with all of you. But thank you all, and we look forward to seeing you all soon.
Thank you very much, Professor Julia, for being able to capture the conference in a nutshell. Thank you so much for supporting that role. And again, would like to thank everyone that has made it happen. We congratulate Dr. Atwine and Mbarara University. The Chancellor is right here with us, Professor Leng of that university, and he's excited. And he's excited to know that that award has gone to somebody from his university. So we have to clap again for that. Yes, with that, I would like to invite Dr. Orem to officially close this conference.
Thank you very much. I think in the presence of the chair of the board of the Uganda Cancer Institute, who is my boss, protocol has it that I think he has to do something as great as that. So let me hand over to Professor Leng.
Thank you, Dr. Jackson Orem. let me begin by thanking all of you who have found time to participate at this conference. I'm very thrilled to note that one of our employees at Mbarara University of Science and Technology in Mbarara is the winner. I'm glad the conference has been carried out via virtual facilities. And yesterday I was not able to attend the opening ceremony, but I watched it online, right through, from the speaker, from the CEO of Uganda Cancer Institute speech, right through when the guest of honor arrived. It was all live on TV. And I think it was very good, and we appreciate the role of Uganda Broadcasting Corporation in airing this and putting it online. I would like to thank the committee that organized this conference. It's not easy, especially during this time, critical time of COVID lockdown. And I'm glad that we've been able to have the final session where we listened to varieties of presentations from cancer management, cancer care, palliative care, and how the two relate. And I would like to take this opportunity to thank our chair, Fatia Kiage, for leading this discussion group today. It's now my greatest pleasure to declare this conference closed. Thank you all for coming.
Institute, together with the Palliative Care Association of Uganda, in partnership with the Ministry of Health, will host the 3rd Uganda Conference on Cancer and Palliative Care on 23rd and 24th September 2021. The theme of the conference is Cancer and Palliative Care in COVID-19 and Other Challenging Situations. This year's conference is a unique one and will be held virtually, with some sessions broadcast live on UBC TV. We will have panel discussions, plenary sessions, and workshops, as well as presentations of abstract, where scientists will share latest research on cancer and palliative care. This conference will bring together at least 400 policymakers, researchers, health providers, patients, and the general public who will be watching online. I encourage you all to register for this important event